Hello, everyone. Welcome to our inaugural webinar on innovating healthcare, the emerging field of pharmacogenomics and personalized medicine. This is Zaina Al-Mahairi. I am the leader of IVPN Personalized Medicine and your host for today's session. Holding a doctorate in pharmacogenomics, I'm thrilled to discuss this subject. And not because only it's my expertise, but also because it's a pivotal area in the modern healthcare. So to set the stage, I would like to introduce you first to the IVPN and personalized medicine and our objectives in this group. So allow me to share my slides that introduce to you this group. So our webinar is about the emerging field of pharmacogenomics and personalized medicine. And the objectives of personalized medicine group in IVPN is to deepen the personalized medicine knowledge through enhancing the understanding of pharmacogenetics and pharmacogenomics and other branches of personalized medicine for improved patient care. We are aiming to support early career pharmacists by providing resources of guidance and help to enter this field and take it as their career path. Also, we are aiming to disseminate knowledge through hosting webinars as this webinar and others, hopefully in the future, to share the latest updates and practices and research of personalized medicine. Also, we are, one of our goals is to build a supportive community through developing a network of pharmacists who are interested in this field and are planning to implement it in their regions. Also, we have the aim to encourage research through promoting research and innovation in personalized medicine to the eventually advanced patient care. Finally, our last but not least is to establish global partnerships through partnering with international entities to enrich our community and knowledge and resources for personalized medicine for our audience and our listserv participants. So without further ado, I would like to start this webinar by identifying the learning objectives of this webinar. So hopefully by the end of this webinar, you'll be able to define pharmacogenomics and personalized medicine, explain the main concepts in pharmacogenomics, and you will be able to identify the pharmacist's role in personalized medicine and pharmacogenomics and state the patient perspective and their understanding of from personalized medicine and pharmacogenomics. So saying that, I would like to start by introducing our first speaker. But before starting, I would like to share with you a new experience that we had, which is actually, allow me to stop sharing my screen. So, and because after we have the list of registrants, we took a group of early registrants and asked them a question: what are you expecting from this webinar? I would like to share with you their expectations and introduction to feel that we a little bit know more about each other. We are the speakers and the audience. So allow me to share my screen again with this Miro board. Just give me 1 second. Oh no. Stop. I'm sorry. So I don't want to, let's start with I'll share later the Miro because I couldn't share it right now. So let me introduce to you our first speaker, and I'll share it later on the insights of the of the audience. So I would like to thank Dr. Nancy Hakouz, who is the first speaker. It's my pleasure to introduce her. Professor Nancy has been a professor at the School of Pharmacy, University of Jordan since 2012. She attained her bachelor's in pharmacy from the University of Jordan, and finished her PhD in drug metabolism and pharmacokinetics from the University of Manchester, UK. She was the founding dean of the Faculty of Pharmacy at Zarqa University in 2010. And in 2013, Professor Hakouz held the position of vice president of Zarqa University, in addition to her position as the dean. Dr. Hakouz's research has focused mainly on drug metabolism and pharmacogenomics of the Jordanian population. She was part of a great team that researched genetically isolated populations in Jordan, especially Shishan and Circassians, mainly studying diabetes, hypertension, and metabolic syndrome of these populations, related genes, of course, on these populations. Professor Hakouz received prestigious award, actually, for outstanding achievement in xenobiotics research by a scientist from an underrepresented nation from the ISSX, which stands for the International Society for the Study of Xenobiotics, in 2022, and she received this in Seattle, Washington. Then this award was granted to her actually because of her sustained contribution to and several years of work in the field of drug metabolism and pharmacokinetics. So over the years, Professor Hakouz has been an outstanding example of a female researcher, a team builder, an administrator, an academic, and most importantly, a mother. And actually, she was and she is a true role model. So we are lucky to have also Professor Hakouz as our IVPN Personalized Medicine Advisory Board. And we are very glad to have her here today for her presentation entitled Unlocking the Power Within, Exploring Personalized Medicine and Pharmacogenomics. So Professor Hakouz, the floor is yours.
Thank you, Zena, and thank you, IVPN, for inviting me to talk about and introduce pharmacogenetics. I'd like to share my screen, if it's okay. Can you see my slides?
Yes, we can see them.
So as Zena was saying that I'm going to introduce the personalized medicine and the pharmacogenetics. Now, whenever we talk about personalized medicine, basically we are talking about precision medicine. If you go to the Wikipedia and look for the definition of personalized medicine or the precision medicine, it's a medical model. And basically this medical model that separates people into different groups. The whole idea is basically personalizing everything. So we're talking about medical decisions, practices, interventions, and or products being tailored to individual patient. And this is based on their predicted response or risk for a disease. Now, the personalized medicine and the concept of personalized medicine is a buzzword, and it has been recently talked about a lot in different publications. But actually, it's not a new principle. Now, in the Pythagoras, which is he's known as a philosopher and a mathematician in 510 BC. Now, he had a strong obsession with food and his relationship with the fava beans. Now, he believed that you should never eat fava beans because they give you gas, and expelling gas took away the breath of life. At the same time, he claimed that the fava beans contained the souls of the dead, and he prohibited his followers from dining on fava beans, perhaps because they made the people sick, and sometimes fatal conditions might happen, as we all know, as a disease of favism. And he was the first person that talked about that, how people react differently to fava beans. Now, if we talk about 1900s, we have William Osler. This is a famous Canadian physician. He was talking about the variability, and he said that the variability is the law of life. And we know that no two faces are exactly the same. We are quite different in the way that we look. We are quite different in our expressions, in the way that we feel. So he was stating that as no two faces are the same, so no two individuals, they would react alike and behave alike under abnormal conditions, which is known as diseases. And this is basically the concept of personalized medicine. Now, as I said, it's an emerging approach for disease treatment and prevention, depending on the individual's variability, genes, environment, lifestyle of each person. And today they are talking personalized medicine as the concept of the 4 R's. Now, whenever we say the 4 R's, basically we mean determining the right drug in the right dose at the right time for the right patient. Now they added another R. This is 5 R's. We're basically talking about the right disease. So the concept of personalized medicine is the concept of the 5 R's. Now, when we talk about, again, we're talking about the concept. Again, it's not the same as one size fits all. It's not the same suit that fits everybody. And whenever we talk about one size fits all medication, this is the way that we practice medicine. Basically, we say that disease treatment, prevention strategies are developed for the average person, and less consideration is basically related on the differences between individuals. So the present day medicine basically talking about one size fits all approach, where we are using the same medication for the same diseases for different individuals. Again, as I said, this is the traditional medicine, one size fits all. Now, the new concept of personalized medicine, that you tailor your drug depending on the individuals. Most of the patients will respond to the normal dose with minimal side effects, but somebody would need a lower dose. Others might need a higher dose of the drug. And sometimes we have to change the drug totally. And this is basically the concept of personalized medicine, because at the end of the day, we want to increase the efficacy of drugs and decrease the toxicity. And whenever we say the personalized medicine, we have to take into consideration everything. Now, epigenetic modification, behavior, environmental exposure. But I want you to concentrate on genetics and genomics. And this is basically what we're talking about. Pharmacogenetics basically is talking about how our genes affect the way that we respond to medication. Pharmacogenetics aims to improve drug development, efficacy, and patient safety. Now, whenever we say pharmacogenetics, it's made of 2 words, pharmakon, which means the drug, and genetics. Basically, we're talking about the genetics of different individuals. Now, in terms of history, we talked about Pythagoras saying that people react differently to fava beans, and William Osler about the variability. But in recent history, we have Vogel. In 1959, he was the first person that used the term of pharmacogenetics. So he is considered as the father of pharmacogenetics. Now, pharmacogenetics basically talking about the effect of a single gene or single genetic marker on the activity of the drugs. Now, these days we prefer to use the word pharmacogenomics, where basically we're talking about the genome, the effect of the whole genome on the activity of the drug, combining pharmacology and genomics. And this concept was introduced more after the Human Genome Project, where basically we're talking about the omics. Wherever we're talking about pharmacogenomics, we're talking about the effect of genomics on drug response. Pharmacogenetics are basically talking about a single gene. And the concept of omics has been introduced a lot. Whenever we say genomics, we mean the study of all genes. Proteomics, we mean the study of all proteins. Pharmacogenomics, a study of the pharmacogenes. And the pharmacogenes, again, these are the genes that are involved in the response to drug. That's why we prefer to use the pharmacogenomics, because we want to introduce all the different genes that might affect our drug. So the goals of pharmacogenetics, or genomics for that sake, is to maximize the drug efficacy, to minimize the drug toxicity or the side effects, and to predict if the patients will respond to this drug. Do we have to change the drug totally for that patient? So the ultimate goal is a rational mean to optimize drug therapy and ensure maximum efficacy with minimal side effects. Now, if we talk about the journey of the pill inside our body, now it can happen whatever the mood of, let's say, transport we're talking about, or whatever the mood of the drug. If we're talking about a tablet, we know that every tablet basically passes through different pathways. So we have what's called the pharmacokinetics, which basically talks about what our body does to the drug in terms of absorption, distribution, metabolism, and elimination, and pharmacodynamics, in which, again, we're talking about what the drug does to our body. Now, concept of the pharmacokinetics is very important whenever we talk about the way that the drugs are behaving inside our body. Again, we're talking about ADME. This, again, abbreviation are used a lot in pharmacokinetics, where basically we're talking about absorption. A for absorption, D for distribution, M for metabolism, E for excretion. Now, the concept of ADME basically is talking about how the drug enters inside our systemic circulation, how it's going to be distributed within the systemic circulation within different body tissues, how it's going to be metabolized, changed, and then it's going to be excreted or removed from the body. So absorption is the process by which the drug enters the body or the bloodstream. Distribution is the movement of the drug between various compartments. Metabolism, we're talking about the mechanisms by which the drug is structurally altered into another entity. And excretion, we're talking about the clearance of the drug, the parent drug, or the metabolites from the systemic circulation. Now, the whole concept of ADME is basically to influence the drug levels and the kinetics of drugs. Now, when we know that the concentration of the drug in the systemic circulation, the concentration of the drug at the level of the tissues basically influences the performance, the pharmacological activity of the compound or the drug. We're talking about the kinetics, absorption, distribution, metabolism, excretion will affect the level of the drug, and this will lead to pharmacological activity. Now, why we're concentrating this? Because one of the big processes is the metabolism. As I said, ADME, M stands for metabolism. Now, metabolism describes the biotransformation, the chemical change that happens to biopharmaceutical substances by enzymes in the body, so that they can be eliminated easily. And the whole concept of metabolism is to excrete the drugs more easily. Now, many of the metabolic processes that involve drugs occur in different tissues, but mainly in the liver, and the enzymes that facilitate the reactions are concentrated in the liver. So if we have any drug, we have a healthy liver, it leads to metabolism and it leads to inactive metabolites, which will terminate the pharmacological activity of that drug. So we need a healthy liver in order for the metabolism to occur as expected. Now, in terms of drug metabolism, basically we have two phases. We have phase 1 reactions. These are called functionalization reactions. And as the figure here, so whatever the xenobiotic, which is something foreign from the body, is going to be metabolized. We have oxidation, reduction, dealkylation, and hydroxylation. These are phase 1 reaction. Again, phase 1 reaction is either we introduce a functional group or we expose a functional group, which will be would be conjugated by phase 2 reactions. These are, again, conjugation reactions where endogenous substances such as glucuronic acid, sulfate, glycine will be attached to the metabolite, and the conjugated metabolite usually is going to be excreted from the body. The whole concept of drug metabolism is to excrete our drugs in more easily and more easy pathway, basically make it more water soluble. The most important group of enzymes that are responsible for phase 1 reactions, we're talking about the oxidation reactions, are a family of superfamily of enzymes that are called cytochrome P450s. Now, these are important because they contain heme as a cofactor, and they function as monooxygenases. Now, cytochrome P450 in mammals, basically they are proteins. They oxidize endogenous substances such as steroids, fatty acids, and also xenobiotics. As I said, xenobiotics, anything that is foreign from the body. And they are important for the clearance of various compounds, as well as hormone synthesis and breakdown. Now, in a recent study, review article, they looked at the factors that will influence the inter-individual variability in drug response. And we can see all these factors gathered together in this scheme: sex, age, race, we're talking about the organ function, mutations, etc. But if we look at the genomic variation in phase 1 reaction, we're talking about metabolism, genomic variation in phase 2 reactions, and genomic variations in the transporters. All of these might affect the kinetics, and we might have mutations in drug target proteins. So in terms of variations, we're talking about either variation that might affect the kinetics of drugs or that might affect the pharmacodynamics of drugs. Kinetics of drugs, we're talking about phase 1 and phase 2 reactions, metabolism. We're talking about drug transporters, and all of these will affect the kinetics. On the other hand, when talking about drug targets, we're talking about the pharmacodynamics. Both of them, the variability in all of these might affect the efficacy and the toxicity of the drugs. And this is the concept of pharmacogenomics. Now, how can our genes affect drug response? This is the whole idea. We're talking about all of these different processes, all of these different proteins. How can they affect our drug response? Now, it comes back to the central dogma of biology. Now, I'm sure that everybody knows that every little protein that needs to be synthesized inside our body is coded for by the DNA. So DNA usually by the process of transcription forms the RNA, while RNA by the process of translation forms the protein. And this is basically the central dogma of biology. Every little protein, every protein that needs to be synthesized is coded for by the DNA. So why do we care about proteins? If we're talking about the drug response, we'll have to know that proteins play a key role in the kinetics and the dynamics of drugs. Now, proteins are responsible for absorption. They are responsible for metabolism and also for the active secretion of drugs. Many targets are proteins, such as receptors, enzymes, and transporters. So we're talking that proteins are important whenever we talk about drug response. So we're talking about central dogma of biology, and the proteins are synthesized by our DNA. So if we have any genetic variation, whatever the reason for that genetic variation in one of these proteins, it might lead to formation of an altered protein structure, stability, and function, and this might alter the drug response, which means make the drugs less effective or sometimes more toxic. So this is basically the concept of pharmacogenomics. Again, we come back to the one size fits all. Now, one size fits all, we can see that we have the same diagnosis for different patients that are giving the same drug. Most of these patients will have good response with severe minimal effects, while others will have good response with severe adverse effects. Others might have no response, no side effects, and others might have no response, but with severe side effects. Now, this is inter-individual variation in drug response. Now, if we talk about this, genetics can explain 5 to 40% of the inter-individual variation in drug response. Now, genetics is not the key, it's not the magic solution for all of these side effects, but it can explain up to 5 to 40% of inter-individual variation in drug response. Now, why do we need pharmacogenomics? We need pharmacogenomics basically to improve efficacy, for the drug targeting, to improve efficacy, to predict activation of products, because we need sometimes the metabolism to activate our drugs, to prevent adverse drug reaction, to enable drug development and the discovery and development, and to develop targeted drugs for cancer therapy. Pharmacogenomics is important for all classes of drugs, but they are more important whenever we talk about cancer therapy because of the side effects of the drugs that are used for cancer therapy. So what is the hope? This is basically the hope. The hope is that every one of us will have their own genetic makeup. And whenever we want to visit a pharmacy, basically we'll have our genetic makeup with us, which basically will help the pharmacist to give us the best drug in order to have, again, the maximum efficacy with the lowest side effects. And thank you.
So thank you, Dr. Nancy, for this great presentation, and it was very insightful. And I know some of you have questions, but I would like to ask you to write them down in the Q&A section, and we will get back to them before the end of this webinar. So thank you again, Professor Hakouz. And I move now to, without further ado, to introduce our second speaker for today, who is Shahina Fakir. Dr. Fakir is a registered pharmacist in Ontario, Canada, practicing as a pharmacy manager in the city of Waterloo. She obtained her bachelor's in pharmacy from Rhodes University, South Africa. She is a certified pharmacist in immunization and injections, specialty biologics training, and she works as also an educator in diabetes. Currently, Shahina is completing a certificate in pharmacogenomics, and soon she will be a pharmacogenomics certified pharmacist and implementer, hopefully. So she is she generously agreed to work with us in the IVPN personalized medicine as a consulting mentor for those pharmacists who are willing to pursue a similar journey as her. And she is sharing with us today her expertise in this learning journey through her presentation entitled Empowering Pharmacists, a Personal Odyssey into Pharmacogenomics. So Dr. Fakir, the floor is yours. Please go ahead.
Hello, everybody. Thank you so much for joining us today. Thank you, Dr. Nancy, for that mind-blowing presentation about the pharmacogenetics world. I'm going to share my screen over here so you can see my slides. All right, so today I will be talking about the pharmacist portion of the webinar. And just to add on to what Dr. Zaina, thank you so much for the wonderful introduction. And I just want to emphasize that my entire career has been within the field of retail pharmacy, community pharmacy. So I will hope that the pharmacists who are practicing and in retail will be able to relate with me in this journey of implementing pharmacogenomics. I have no disclosures to make, affiliations or endorsements, no payments. My contributions to IVPN are completely voluntary. And some of these slides have some of my experiences and opinions put in there, but I've tried to add some evidence-based information as well to go along with it. So I'm just going to share some objectives of my portion of the webinar really quickly. I would like to highlight some of the important prominent clinical practice issues that I've encountered where I had to relate it to pharmacogenomics and you know, dig a little deeper into why we need pharmacogenomics in community practice. I'll also be able to explain some of the reasons why pharmacists are most suitable to be able to implement pharmacogenomics in practice, as well as understand the roles of pharmacists in different roles that they can play in the field of pharmacogenomics. So just starting off a little bit with my story of how I came across pharmacogenomics. Incidentally, I came across this study in 2018. I don't remember hearing anything about pharmacogenomics in my undergrad, and I think pharmacists will relate to that. This study was called the ICANN-PIC study, and it was a study done in a community practice. And this study really hit home for me for two reasons. One is because it was done under the same banner chain that I work for. And also it is done in community practice in Toronto, which is basically an hour away from where I live. So it was really, really fascinating for me. It was a point of care testing done in the pharmacy. Participants were able to take a swab, send off the swab to the lab. And then when the results came back, these were the results, these were the changes that they made to the therapy. So 60.3% of all the participants required a change in therapy. 13.2% were changed, doses were changed. 4.4% required a complete discontinuation of certain medications, and then 22% of participants required increased monitoring of their medications. And the study also highlighted that community pharmacists are ready to adopt pharmacogenomics in their practice and offer pharmacogenomics testing as a point of care test. So at that time, obviously, I didn't have any pathway, or there were no such studies or anything that I could undertake to make myself confident in this field. Keeping it at the back of my mind, I continued my journey, taking off on other certifications. And then around 2023, 24, so very recently, I came across a lot of sources, papers, evidences, advocates in the world of pharmacogenomics, and that restarted my journey to start learning more about pharmacogenomics in pharmacy practice. Obviously, along the way in 2020, 2021, 2023, there are papers submitted by the same group of people who did the ICANPIC study, and they were all done within the same banner, same pharmacies in community practice. So very, very relatable that this practice is not new and it's not something foreign to community practice. So what are these clinical practice issues that I'm talking about that will need the help of pharmacogenomics perhaps in the future or even now? One of them is polypharmacy and inappropriate prescribing, which we have seen in great detail. We see people with more than 5 medications. I've seen people with 15, 19 medications at the same time. There are a lot of studies that have shown that pharmacogenomics can be used to what we call deprescribe. So reduce pill burden, remove some of the medications that these people are on, so that, you know, there's an improved quality of life overall with deprescribing. We've also seen something called trial and error in prescribing, where people who are, especially this is common in antipsychotic prescribing, where you basically keep changing medications until you find the one that works for them. And that causes a big delay in achieving the health outcomes in these patients. So again, studies have shown that pharmacogenomics can be used to find the right medication, the right dose, for the right patient, the right time, the first time around. You don't have to wait and keep trying different medications. We've also seen poor or no response to drug. I've seen people take proton pump inhibitors, for example, in double, triple doses, to get a response. And that's not necessary sometimes. If you would know their genetic profile, you can provide a proton pump inhibitor that is not affected by that particular genetic makeup. We've also seen a difference in adverse effects. So like Dr. Nancy mentioned, that this can differ there's inter-individual variability in how people respond to medication. Some people will have myopathy, for example, by using statins. Some people will end up with some skin reactions, for example, Stevens-Johnson syndrome with certain anti-epileptics. And this is very, very much related to the genetic makeup. And also some fatalities that have happened. There are papers out there showing preventable deaths that have happened in chemotherapy. One of the most common examples is 5-fluorouracil, which is capecitabine, used in certain type of cancers. And this is completely preventable if there is a preemptive pharmacogenomic test done before starting chemotherapy. Some of the places are mandating that. So I'm pleased to say that the province of Ontario here in Canada does that. And I hope other countries and provinces and institutions and regions will follow the same. So just why do I think then that pharmacists have a big role to play in pharmacogenomics? One is because we are the experts in medication management, right? So we are the experts in drug pharmacology, drug interactions. We do this on a daily basis, whether you're in hospital, in community, in retail. This is the core of our practice. So if you're doing medication management without a genetic profile, we are basically working blindfolded. So I think it is very, very important to have the genetic profile to be able to make certain decisions. Having said that, pharmacogenomics is just an additional tool to help with medication management. It's not supposed to replace your clinical decision-making ability or the pharmacokinetics or the other drug interactions, or, you know, like individuals are different. The pharmacogenomics only adds the ability to personalize care. And also there is a global trend of moving towards a more of a clinical services-led model in pharmacy. It's a global move towards clinical services and intuitive services by pharmacists rather than dispensing models, which are becoming tradition and highly, highly automated, especially on this side of the world and hopefully in other places as well. So what is the evidence that pharmacists have a role to play in pharmacogenomics? I'll share with you this paper over here as a position statement by American Society of Health Systems Pharmacists. So this one is a body, an important body that has a position statement that cites the importance of pharmacists' involvement in pharmacogenomics. It emphasizes the fundamental role that pharmacists play, and they have the evidence that pharmacists can play a role as leaders, as educators, advocators, as well as collaborators in the world of pharmacogenomics. And they have found that the involvement involvement of pharmacists in pharmacogenomics has helped highly in clinical decision making, and the results have been phenomenal in terms of improving patient outcomes, reducing adverse effects, increasing adherence, as well as appropriate medication selection for patients. And just highlighting the leadership that pharmacists have undertaken in pharmacogenomics. I invite you to see this paper called Pharmacogenomics Competency in Pharmacy Practice, a Blueprint for Change. This one is an article published in the Journal of American Pharmacists Association. It highlights the leadership roles that pharmacists have undertaken in pharmacogenomics. And one of the biggest roles that pharmacists have played in the world of pharmacogenomics is to come up with this body here called CPIC. CPIC stands for Clinical Pharmacogenomics Implementation Consortium. This is a pharmacist-led initiative. It's a body that provides actionable guidelines of how to implement pharmacogenomics. When you have a genetic panel, there has to be some guidelines on how you can apply these genetic details or genetic data that you have into actionable guidelines to make therapy changes. So this is the body that's involved with that. If you will be dealing with pharmacogenomics in your career, this is like the gold standard of guidelines that you will refer to all the time. And this was a pharmacist-led leadership that helped with implementing this. And also, this paper highlights a most important barrier in why pharmacists have been a little bit slower behind in implementing pharmacogenomics in practice. And this is because there's a perceived lack of competency and education among pharmacists. The pharmacists don't feel competent enough, or pharmacists don't feel that their education, they're not confident enough in the world of pharmacogenomics. And now in my conclusion slide, I'll go a little bit into this education part. So concluding my part of the webinar, pharmacogenomics is quickly becoming a standard of practice. A lot of countries are already adopting this in practice. I mentioned about the mandatory testing that is happening before chemotherapy in lots of countries. And a lot of community pharmacists are already implementing this. As I mentioned, the studies are ongoing, but also community pharmacists here in Canada and in the province of Ontario and other provinces as well are providing pharmacogenomic tests as a service, and they're using those results to make clinical decisions. In terms of the competency that we talked about, well, we have no choice. At this point, we will have to become competent in this area. Dr. Nancy mentioned that we will have patients coming in, handing a prescription along with handing us their genetic data as well. And so if you're not confident in this area, then you will not be able to make those clinical decisions using the genetic data that you're providing. Not only do we need to become competent, we have to advocate for PGX integration. In the United States, providing a pharmacogenomic test is considered an ethical consideration, an ethical responsibility by pharmacists, because this is standard of practice, and this is important to make clinical decisions. And also providing education. So we need to not only become competent, but be able to provide this education to other healthcare providers who have never heard of this before, for example, or don't know how to integrate this into practice, to our colleague pharmacists, as well as the patients. So, you know, we have to educate our patients why we think pharmacogenomic test is important for them. And we can't do this alone. Interprofessional collaboration is absolutely key to implementing correctly and implementing this to help to get the improved patient outcomes that we're looking for. This is not going to be an easy path. Challenges exist in this path, where I've seen patients that don't understand why they need a pharmacogenomic test. So you have to explain it to them. It's an uphill battle. There's a physician pushback or prescriber pushback where they feel that this is not necessary, or where's the evidence. So you have to be really armed and ready to, you know, be able to show them the evidence where pharmacogenomics has played a part and made significant changes to people's lives. So that is my part of the webinar. These are the references that I've used to come up with my slides. So feel free to jump into them and have a look at all the different the resources that I've used and read up a little bit more. Feel free to pop in any questions in the chat during the Q&A for me. If you have anything to say or to add on, I will be more than willing to answer. And enjoy the rest of your webinar. Thank you so much. And thank you so much, Dr. Zaina.
Thank you so much, Shahina, for this great talk and for sharing your inspiring story. It was really interesting to listen to you and to know about your how did you start with getting interested in pharmacogenomics. And I think a lot of the audience will relate to your story. So please, if you have any questions, don't forget to ask to write them down in the Q&A box. And finally, I am delighted to introduce a colleague and a friend, Ms. Lilas Dabarie, as the third speaker for today. Lilas is a core member in the IVPN Personalized Medicine and a researcher and the content creator for the IVPN Global Health as well. She got her bachelor's degree in pharmacy and is currently working as a research assistant in pharmacogenomics at the UAE University. She has experience in community and hospital pharmacy in addition to public health, education, and business administration as well. For the past 2 years, she has been working directly with patients and listening to their stories and concerns in the first pharmacogenomic implementation study in the country. So Lilas, welcome here and thank you for being with us, and the floor is yours. Please unmute yourself, Lilas.
Okay, can you hear me now well?
Yes, yes. Great.
Okay, let me start all over again. I will share my screen now. Oh, did I? Give me a second. Okay. I'm not able to share my screen. I don't know, cannot press the button. Okay. I can share my screen now. Can you see it?
Yes, yes, yes. Go ahead.
Okay, so thank you very much for having me today. As Dr. Zaina said, she pretty much said everything about me, and I hope I will be giving you some useful information today from my humble experience and also from what I've seen in the literature regarding patients' experience in personalized medicine and more specifically pharmacogenomics. So first, I would like to just let you know what we're gonna be learning today. We want to explore drivers or what motivates the patients to pursue pharmacogenomics or accept it from a physician. Second, we want to know how we can communicate well with the patient, what can be the challenges, and lastly, we want also to see what kind of equity, opportunities, and challenges, what kind of disparities we can see in the societies in different countries regarding pharmacogenomic testing. Now, I want first to show you just a quick facts that in the US alone, we have a huge amount of money spent on prescription medication, mainly for chronic medication. And also, we have most of the adults, they have at least one chronic condition. And if we take in consideration that ranging from 13 to 75% of, depending on the medical specialty, 13 to 75% of medication can use or has a guideline for using, depending on the genetic makeup of the patient, then we can see the importance here of implementing it. Now, I want to start first by sharing a story of my experience, something that I've seen firsthand. Um, I want to tell you about a patient who was, so I'm doing research right now, and this is not something in the hospital like a regular test. This is asking for a participation in the research. But at the same time, we were telling the patient about the benefit that he will get when he will take this genetic test for the statins. So this patient, he came to the doctor. He's been a regular patient. He's married. He's in his mid-40s. Has a wife and children. He has been suffering from hyperlipidemia, just like any other male in this age. Probably he has stress, he has bad diet, not able to exercise, not able to control very well. He have high risk of cardiovascular disease in his family. He's pretty worried about the high cholesterol. But there's one thing, he never felt comfortable taking the statins. So he's been, I think, around 8 to 10 years taking statins on and off, going to different physicians. Each time they tried to prescribe him something different. So he go to this doctor, he would take atorvastatin, other doctor, rosuvastatin, and so on. So this patient, he never felt comfortable. He feels guilty that he's not taking care of his health. His wife is actually mad at him at some point, like, okay, just tolerate the medication, just take it. We don't want you to have a heart attack because of the cholesterol buildup. So until the doctor that I'm working with explained to him about this genetic test, he was excited, and eventually he was one of the patients that were in the intervention, which means we can see their results in the beginning of the study. And it turns out this patient, he has a poor function of one of the metabolizing enzymes for the statins. He cannot take atorvastatin, and also rosuvastatin was affected to a certain point. So he was not making this up. He was actually not comfortable. I've seen some patients reporting some psychiatric changes. I've seen patients having just weird insomnia. So we should take these kind of adverse events or just change in the patient's health we should take it seriously. Now, I just want to show you at the beginning how silly sometimes it can be from the patient's perspective. What the patient hears sometimes from the doctor. There is no choice you have to take. There is nothing to do about it. We can't, you have to tolerate it. Other patients are taking it. Why can't you take it? All drugs have risk and side effects. It's just, it's a known thing. It's a privilege to have access to drugs. You should take it. Maybe, especially for the poorer or less financial state patients who have less medical literacy, the doctor would sometimes treat them with little bit of ego, and he will tell them, you're just privileged to have access to even medication sometimes. Another thing it could be, it should have worked. I don't know why it didn't work with you. It should have worked. And this can be particularly very, very painful for the patient. If you consider that this patient can be a psychiatric patient. Imagine a patient hearing that this should have worked on depression, on some serious mental illness, or some serious other issue. One more excuse or one more thing that the patient hear when they complain about side effects or their risk side effect, they have fear of it, that, okay, if you develop, we will switch you if any problem occurred. One more thing, that it would be irresponsible if you do not comply. One more thing, all of these things, of course, it will lead at the end to non-compliance and worse health outcomes. So we have to put this in mind. If we keep dealing with the patient's concerns in this way, without addressing it, especially if we have now in the modern medicine more ways to tackle these kind of problems, we should not risk having non-compliance and worse health outcomes. Now, I just want to share with you a few graphs that would show this is the therapeutic areas of new FDA drugs approvals. So mostly it's in oncology, probably because it should be like a targeted therapy, more dangerous and serious adverse events. And also we can see the trends in the number of new biomarker drug pairs approved, also by cancer versus non-cancer. So as you can see, both of them, they're increasing from 2000 to 2020. And the trends in the number of new drug approvals with PGX labeling Also, it's increasing, as you can see in the blue color, it's increasing since 2000. So the usually now in the phase where they're developing the drug, they are able to recognize how it's metabolized and if there is any pharmacogenomic test that can be actionable or can have an influence on the therapy. Okay, so now I'm just gonna show you quickly some of the literature that I found regarding patients' insight and patients' point of view. So most of these studies are done in the US, in Europe, but just recently now we started doing it in Arab countries, especially GCC, and hope we will see more later. So findings now reveal that the patients, for example, this study was done in a psychiatry patient. Findings reveal that patients have no familiarity with PGX testing, but they have high interest. So some of them, they have probably some knowledge before. And let's keep in mind that sometimes in the US or the UK, you can see the direct consumer advertising. Maybe it's not very common in the Arab countries, but in the US, it's kind of known, it's kind of common to see it advertised that the patient can themselves make the genetic testing and then take the result to the doctor, for example. So the patients, there was one factor that affected, which can be a social factor if we take it into consideration, that a preference for seeking information significantly predicted testing interest. So the patient who wants to know more about his health, usually, they are interested to know more about the genetic background for his therapy. And later, another study, it was done to evaluate just in general perception, knowledge, attitude in underserved patients. So this was in, you can say, in the lower financial class patients, and how it has the potential to affect health disparities. So keep in mind, these patients, they probably don't have health insurance. They probably cannot afford healthcare, especially in the US. Most of those respondents have not previously heard of pharmacogenetic testing, but after explanation, a significant proportion expressed interest. So keep in mind, people will have interest. Usually, they will have interest in receiving the testing. But in this segment, the cost was, if the cost was not a barrier. So they keep in mind that there might be a cost that they cannot tolerate. So there was worries about the health insurance, if they're going to cover it or not, and disease risk disclosure, privacy, data privacy, and the perceived lack of improvement in care. And also, I want to show you another study. Sorry. This is not the right time. Just give me a second. How much time do we still have? I think I'm almost close to my time.
Yeah. Yeah, go
Okay.
ahead. Yes.
I'm just gonna go very fast.
Yes.
Can you see my screen?
Yes, yes.
Okay. So there was one study that investigated the perspective of the general public on medication use in general and then pharmacogenomic testing. It was for the patients and also for their families. The patient expressed a desire also, and they had concerns about the medication side effects in general and the privacy of genetic information and the costs. So these are usually what the public are concerned about. And they emphasized on the importance of informed decision making and effective communication with healthcare providers. So the patient will not only want to have this pharmacogenomic testing as part of their healthcare plan, they also want to be informed about it. They want to understand it. And they want their healthcare provider to communicate with them well. And this one was done in Belgium, where they wanted to see if the public are interested in pharmacogenomic research testing, and also in general PGX testing, to facilitate its integration into the healthcare. So this was a survey. It has shown that a significant portion of people expressed willingness to engage in research and believed in the potential of pharmacogenomic tests. And the majority supported partial reimbursement of these tests. So again, we're talking here about the costs, and they prefer the healthcare professional to conduct them and access their data over commercial providers. So this point, you might see it different when you go deep, when you deep dive in the literature. You might see it differently depending from a country to a country, a continent to a continent. Where do the people provide to have total ownership of their data? Like they want to have the result and they want to choose to show it to whomever they want, like a healthcare provider, or they would like to have their data in a hospital, in a secure hospital, and only the doctor can see it, and they will trust the doctor to communicate with them about it. So you might see these differences. So here in this test, in this research, the interest in a direct-to-consumer test was low. So because some participants raised the privacy concern. Privacy concerns in general, it's a common issue that's raised in Europe, even not only in biotech, in also other fields. But of course, in general, they showed a positive attitude. One more study showed that this was done also in the US. It showed that the majority of the patients, this was done to assess the patient's experience with two different models of delivery of pharmacogenomic testing, which was direct access testing and PGX clinic testing, whether it was initiated by the patient or by the doctor. The majority of participants perceived tests to be helpful overall in the current and the future healthcare decision making. And as you can see, the total, they agreed to that they have a clear understanding of their PGX result. And specific outcomes included changes to a current medication was little bit less than half, probably because they did not have maybe an actionable, like there's no need to follow a specific guideline, like they have a normal gene maybe. And also they started a new medication because of a certain test, what was 18%. And they are planning to avoid particular medication in the future, 66%. So they have seen probably that they should avoid certain medication, and they're going to make use of this result in the future. Um, there was almost no or little familiarity with the Genetic Non-Discrimination Act. So this act, it's a law that it basically makes sure that the genetic information is should be very, very secured, whether it's a biotech company, whether it's a hospital, and the patients usually have very protective or very guarded, let's say, genetic information by the government. So not anyone can access this one. I'm having a problem again with the laptop. I cannot go to the next slide. Not sure. I hope it doesn't take a while. Sorry. This one. Okay, so I want to share with you now, just briefly, the patient's thoughts, as in quotes, but I don't think I have much time. The patient's thoughts on this. So regarding understanding the test results, usually the patient would say that I take longer time to understand they might want they might sometimes be embarrassed because they really cannot get their head around the information that they're hearing about. So this is where to remind us that we sometimes have to simplify the information for the patient. One more thing is that patients commented on in several research on the delivery of genomic or PGX information. So is it delivered verbally? Is it delivered through a pamphlet? Is it delivered online, by a message, by whatever? So a lot of patients emphasized or mentioned that they like a visual paper, whether it's a paper, it's a graph. They would like to see something and maybe keep a piece of paper. Uh, this usually help them keep the information and make use of it. And you can find many research regarding this area about the PGX delivery. Okay, and understanding of the test results. Usually, as we said, the patient either will take the information from the company, which if he do the genetic testing, direct to consumer testing, or they will have a physician or a clinical geneticist who will interpret the information for them and guide them for their therapy. Uh, Usually, the patient would like to have it explained for them very well. They want they want this the simple information. They don't want to see full of numbers. They don't want to see letters. They want to know what it means. So, how do patients access PGX testing in general? We have three areas or three types. The one that we talked about, direct to consumer genetic testing. The number two, it is in between, which is provider mediated genetic testing. And the third one is clinic based genetic testing. Usually, the first one, the patient will do it by his own decision. He will contact a company, he will send his saliva sample or whatever, and he will have his results for him. Probably the company will supply a kind of consultation regarding his result from a health professional with the company. Number two, the provider mediated. So probably the patient will do this outside sometimes, but the patient will have a connection with the doctor about it. He will talk about this test with the doctor, and the doctor, his physician, his primary care physicians, will know about it, and he will interpret for him. And this one, the clinic-based testing, it's just like any regular test that's done in a hospital. It's initiated by a doctor, suggested by the doctor, saved at the end, probably in the patient's electronic medical record, and it's for use by the doctor. Now, regarding this topic, there was a study done to describe the characteristics and perceptions of direct-to-consumer PGX testing, to discuss their results with their primary care physician. And this was a survey done before the testing, 6 months, and after the testing. So patients at the beginning, they planned 63% they planned that they will share the results. Okay, when I have my results, I will share it with my doctor. But on the follow-up, only 27% planned to do so. And 8% reported that they shared it probably with another physician, like two physicians or more. And common reason for not sharing, probably that they saw that the genetic testing was not significant enough, it didn't have any significant implication on their health, or probably the patient just like anyone else, life took him. He did not have time to do it, he ignored it. So patients who discussed it, they were very satisfied, but only 18% were not satisfied. Probably they had concerns about the actionability of the results or use in care. How much is the physicians actually implementing this?
So, excuse me, Lelas, because we are over the time of
I didn't
this time. So
forgot.
I'm sorry.
Okay.
We
So
have
I just want to show you.
conclude.
Okay.
Thank you.
So I just have 3 slides. I will just finish now. So I just want to let you know one thing, everyone, that when it comes to race and ethnicity, we don't want in pharmacogenomic testing to make any kind of okay, so this certain nationality, this certain race can take this kind of drug. It's not very accurate. We cannot use this in genetic testing. Race and ethnicity are social, they're not biological constructs and should not be a predictive of genetics. And last thing, I want to tell you that nothing is so healing as the human touch. Always remember that you're dealing with human beings, address their concerns, listen to their stories, and just try to do a more holistic, always try to do a more holistic therapy. So thank you very much.
Thank you, Rilas, for this excellent talk. And sorry for interruption, but so we have to.
Sorry, I think more than my time.
No worries. I hope our attendees are not. We took extra time from their weekends already. So please, I'll move directly to Q&A session, and I'll leave the floor for Zeina Jandali, our colleague. She's a pharmacist with a master's in bioinformatics, and Muhammad Ali, our enthusiastic colleague also, who is a vice chairperson for the IVPN student also, and he is an active member of our team in personalized medicine. Please lead this session of Q&A, and let's kick in. The floor is yours.
Thank you, Dr. Zain. First, I'd like to take a quick moment to thank our speakers for their insightful and inspiring presentations. Okay, so now moving quickly to our Q&A section. Our first question comes from Abdulrahman. He'd like to know what are the practices towards pharmacogenomic testing among healthcare providers, physicians, and pharmacists. This question has been answered by Dr. Nancy by sharing a recent publication which taking large numbers of studies all over the world, where they found that pharmacists and pharmacy students have positive attitudes towards pharmacogenomics. I hope this answered your question. I don't know if you have any further discussion on this topic. Okay, so we move to the next question from Malika. She's saying, how can we implement pharmacogenomics in a country where genetic profiling is not available yet? Well, this is a very important question. I believe it was addressed to Dr. Shahina. Please.
Hi again, everybody. Yes, that's an important question. And honestly speaking, I'm not sure how you would be able to do, if there are no labs providing genetic profile testing in your country yet, which I would be very surprised. I mean, I'm sure there are DNA labs all over the world. They might be not providing a pharmacogenetic profile yet or a panel, but they might actually be doing other types of DNA testing. There's a prenatal DNA testing. There's so many different types of gene testing that are done all over the country. Can I ask which country you're referring to? I can always look it up and connect with you back later with an answer. But to my knowledge, I'm not sure if there's any country that does not do genetic testing at all. Any other colleagues of mine, any comments from your side, any experiences with, is there any countries that you know of that have absolutely no genetic panel at all?
So it's not about panels. It's a little bit limited to the States maybe, or Canada and some countries in Europe, but there are limited or specific tests that are available here and there in countries in our region and the Middle East maybe. So, but I believe that there's a shortage of availability in testing but it is actually a loop. If we encourage the clinicians to order these tests, then the labs will bring them because they have the technique. They have all the labs have can do sequencing or PCR or PCR-based genotyping. So it's there, the technique is there, the platforms are available already. The thing is there's no requests from the clinicians. They are not asking for these tests, so why the labs should provide them? So it is a loop. We have to increase the awareness about these tests among the healthcare practitioners. We have to increase the awareness among the public about the importance of these tests. And we have to make these available in the labs as well. They will be available as long as there is a requirement for them. So this is from my
solution
point
that
of
I can
view.
think of currently is I know pharmacists in other countries where they were really keen at implementing pharmacogenomics in their practice. And what they did was having to send their samples to a different country. So they had to import their samples. They collaborated with, for example, US or Canada-based labs. It's probably going to cost you a fortune to do that. If there are patients who are willing to go that route, you know, great, that's perfect. But that's the only solution I can think of as of now. If you don't have any labs providing the pharmacogenomics test, you might have to import it to a country that does. So you have to collaborate with a lab in another country. And then they will provide you with the report, you know, through email or some form of secured method to your as a healthcare provider.
Thank you, Dr. Shahina. We have another question addressed.
I'm sorry, but Dr. Nancy wants to add on something, maybe Zaina before.
Implemented, and this is related to our discussion right now. Can you please clarify how it's
I think thank you, Zaina. I think what Dr. Zaina was saying is the right way to do it. It's a circle where basically we start with people asking, physicians, clinicians asking for the pharmacogenomic testing. At the same time, having the pharmacogenomic testing or the education about pharmacogenomics and the importance of the pharmacogenomics testing in our curricula, in our schools and faculties. Again, we're not talking about, Shahina was touching on this, we're not talking about a magic solution for everything. It's just part of the solution to personalized care, to have more personalized care. Basically, we need to take the personalized medicine into account. And part of the personalized medicine is the genetic makeup of the different individuals. So again, it depends the way that every country is dealing with pharmacogenomics. But I think at the end of the day, we have to have more dissemination, more education at all levels to understand the importance of the pharmacogenomic testing. Thank you.
Thank you, Dr. Nancy. Our next question is from Ala. I think, how could I promote my career at pharmacogenetics? She's working at medical informatics field now, but she wants to career shift to precision medicine and pharmacogenetics. How can she promote her career to pharmacogenomics? I think this question can be answered thoroughly in our next webinar in details, I think.
Yeah, thank you, Zaina, to highlight this, because we are planning our next webinar to be about the steps on how to, what the toolkit that you need about to enter this career path. So this is the answer, and for now, and stay tuned to the next webinar. Okay, so from Suleiman, what are some of the barriers to a mainstream implementation of pharmacogenomic guided prescribing? Who would like to answer? I don't know. Or who this? Lilas, we are not hearing you. We're not hearing you. Your voice is not clear.
Is it better now?
Yeah. Now it's working.
Yeah, sorry. So I'm answering that I believe it should start with the overall environment, like of the country, let's say, or the city. it should be ready to tackle such kind of challenges. It should start with the healthcare facility itself, from the management, from the vision that they have, all down to the doctors, to the departments that it will be implemented in. Because what I have noticed that even doctors who have like very shiny career, they are very good at their field. They are working in the top of the hospitals. They still are not exactly qualified to be working with pharmacogenomic testing for their patients. It's not exactly like that, but it should be part of the healthcare system vision. So, for example, in the UAE, we want to do this. The government is trying to do this. They're doing research. They're spreading awareness about it more and more than before. They're prepping the environment here. And also hospitals, they're talking about it. You see it in conferences. So this is how it starts slowly and organically. You don't just force it into a system. It has to grow from inside and should be adopted by everyone, from doctor to pharmacist to technicians, of course, including the management. I hope I answered part of it.
Thank you, Dr. Lilas.
I'd just like to
Okay,
add some of the barriers in implementation. Sorry, Zaina, to interrupt. Some of the major barriers of implementing pharmacogenomics is seen as, first of all, there's ethical considerations. This is DNA data. So a lot of people are very, very sensitive about their DNA data. This is your lifetime information, right? It does not change. There's one test and then this does not change for lifetime. So there's a lot of like storage issues. A lot of the EMRs are not integrated yet to include the genetic data into them. So that's one of the biggest barriers. And then we also mentioned about education. So again, you know, professionals don't feel very confident in this area yet. This is an upcoming field, so I'm hoping that this is a temporary barrier to implementation. Again, and like someone mentioned, that there might be labs that are not offering it. You know, that could be an implementation barrier. Also, there's the patient buy-in and there's the physician buy-in as well. So, you know, as I mentioned, it is an uphill battle. You'd have to be able to explain the value of this test to the patients, and then you have to be able to explain the value of this to the prescriber, that how much of the change can come about with this test before it can become something that, you know, people are used to. So hopefully that's not too long before we reach that stage.
Thank you, Dr. Shahina. Also, again, Rasha is asking, what are your suggestions to spread the knowledge about pharmacogenomics among healthcare providers and patients in our Arab countries? I think this question has been answered through this webinar and by our speakers. Okay, so do you have any comments on this? Any specific guides or? Okay, so.
I think
our
just
next question.
if you're a healthcare provider, just doing exactly what we are just basically now doing. Spread awareness, talk about it, whether it's on social media, whether it's between your colleagues in your pharmacy group, send information, teach each other new things. This is how it starts, with baby steps.
Zaina, I can see that Ali has been raising his hand for a while now. Maybe we can give him the chance to talk. I'm not sure if we can, if you are able to do so, or I should do this.
Do you have any question? You can type it in
Yeah,
the
you
Q&A.
can you type it, please, Ali? Okay. So he's not
Okay, while
raising his hand anymore.
Okay.
You have more questions?
Yes, we only have 2 questions, I think. As an undergrad, are there specific courses to enroll online to understand pharmacogenomics? Abdurrahman wants to further his knowledge in the field of pharmacogenomics before graduating. I think there are online courses, free online courses. I think Coursera has courses.
Yeah.
I don't know if anyone has.
Shahina, you wanted to share with us something. Do you have it on hand right now?
Yes, I do. This was a very anticipated question, so
yeah.
I was very prepared to this. I'm so glad somebody asked me this question. Okay, so one of the resources that you will use in your pharmacogenomics career is PharmGKB, and I hope we have a webinar soon, Dr. Zaina, about the resources that we'll use in pharmacogenomics. PharmGKB is like the go-to standard for everything. So you can see over here, I'm on PharmGKB. Can you see my screen?
Yes.
Okay. So when we scroll to the bottom of the screen, you will see resources, and then you go to educational resources over here. Once I click on educational resources, and then you go all the way down here, external resources for pharmacogenomics education. Your answer is right there. So whatever is mentioned over here on this, these are worldwide resources that you can use, courses that you can use. They are right here. There are videos. Here's certificates and courses and continuing education. So whatever you choose over here, unfortunately, they're not cheap. They're pretty expensive, depending on what you do. If you're doing a master's in it, for example, or you're doing some graduate programs, or if you just want to do certificate courses, everything is here. So feel free to visit the website and choose what you want to do from there.
Yeah, thank you for asking this question. Any more questions?
Recording of this webinar, I think, yes.
Yeah, and it will be available on the website.
Dr. There is a question on the chat from Serene Shilbaya. She's saying about this is an evolving science and many markers are of medium strength in terms of evidence as rated by the CIPIC, and their cost-effectiveness ratios are not justified. We need more research in different parts of the world. Genetic markers or genetics makes differently. It's governed by ethnicity and upgraded by environmental factors. Again, this is part of the personalized medicine that we're talking about. Now, we need more research. Yes, I agree with her. We need more research on the genetics in all over the world, not only in the Arabic countries. And the whole idea about having research just to see if we are as Arabs or we are as Jordanians are quite different from the other parts of the world. Now, CIPIC, basically, as Shahina was saying, it's basically based on pharmacists, and all the information from any study in the world is included in CIPIC. Now, PharmGKB, this is another resource where basically they grade the actual research and the evidence of that research into clinical practice. And they grade it if it's a good, or they have a grading system where basically they tell us, according to the study, if this is good or it's not a very strong evidence. So I think she's right, but at the same time, we have to start somewhere. Now, research has been done all over the world, in every country is being done. Sometimes the research is very, very modest, depending on the country. But in other countries, for example, if we're talking about the Gulf countries, we're talking about Qatar, and we're talking about UAE, you have a lot of research, especially because you have the genome projects that in your countries. So we have a lot of evidence, which is very close to the evidence which is presented by CIPIC and the other websites. For example, we're talking about PharmGKB. So I am with her with that we need more research, but this should not be the reason why we stop pharmacogenomic implementation, because I think we can depend on a lot of the pharmacogenomic guidelines from CIPIC, PharmGKB in our practices. Again, how to implement it, how to put it in our systems, it's a big cycle. It starts, again, we're talking about education, dissemination, as Lilas was saying, dissemination in every platform that we have. At the same time, people were asking about teaching, and we need education on the level of the universities, and education as continuous education after graduation. So it's a big circle, and hopefully we have to start baby steps, Lilas, and these baby steps basically will lead us to what we want. At the end of the day, what is the whole point of pharmacogenomics? Is to, again, patient care. We want the best care for our patients. part of the best care is taking the genetic makeup of the individuals in order to describe the different type of medications.
Yeah, thank you, Dr. Nancy, for this.
That was a very comprehensive answer. Thank you very much. And thank you, Sirin, for your contribution to the chat. That's it for the Q&A. Ali is saying microphone is not working. Shaheen answered my question. Okay, very good. He just wanted to add that even if a country doesn't have services locally, it is cost effective to transport samples internationally. Yes. Okay. Thank you very much, Ali. And that's it.
So by this, we conclude that I think Muhammad Ali wants to add, he has his hand raised. Please go ahead, Muhammad, before.
Okay, there is another question from Amani Samir. She would like to ask Dr. Shahina if she can clarify how can pharmacogenomic testing implemented in community pharmacy.
Yes, for sure. So there are different implementation models that have been studied, and there's still studies ongoing about which one is going to be the most comprehensive or the most practical model to be implemented in community practice. So there are point-of-care testing models. So these are when you have the actual kits in your pharmacy, you do the point-of-care testing. That'll depend on your country's jurisdiction and your laws. Because in certain countries, that is a controlled act. You can't just take a swab from a patient unless you're actually allowed to do that. And then these things changed on our side during the pandemic, when we were able to do the COVID-19 testing in stores. So taking the swab became less of a controlled act. So we are now able to take this and send it away to the labs. So that is a point of care test. And then I think Ali last touched on different kinds. There's a direct to consumer model as well, where you can send the patient does it themselves through a lab. They have the report, they bring it to you, you do the interpretation of that, depending on your expertise in this model. If you're collaborated with a physician, you can ask them to provide the pharmacogenomic requisition this is called the collaborative model. So you can ask them to provide that request to the patient. The patient goes on and does their own, lab work. And then the provider, the physician or the pharmacist involved gets the report, and then you make decisions based on that. And then there are different models. There's like the core model, and then there is the comprehensive model where you have the full medication management. The core model is usually 4 to 5 medications, and it just depends also on a lot of what kind of practice you are in. Are you in a busy pharmacy? Are you in a less busy pharmacy? Are you in more of a clinical services model? Are you in hospital? It'll just depend on where you are, but there are tons of different implementation models out there, and you can read about them as the more you look into it.
So we are good to go now to the Kahoot to conclude our webinar. So just a few more seconds and we will leave you alone. So before we conclude, join us for a quick interactive quiz now. Scan the displayed Kahoot. I will share my screen now. One second. So you see my screen now? Okay. Oops. Okay, go ahead, please. Please scan the barcode, the QR code, and join. So we have only one.
Can we join? Can we put the questions? Can we join?
You put the questions, you can join.
Yeah.
So you are not feeling like taking a quiz? Okay, great, great. We are having some more participants. We have 3 participants. No more. Okay, thank you for joining. Great, great. So wait for a few seconds and then I will start. Okay, 5, 4, 3, 2, 1, and I'll start now. Okay, Ali, you just joined at the last moment. Okay, let's start. So pharmacogenetics primarily focuses on the study of drugs in animal models, individual genetic variation influencing drug response, drug manufacturing process, or the effects of drugs on specific tissues. 6 answers now, 7, 5. Okay, so the second answer was the correct one. Okay. The goal of pharmacogenomics is to standardize drug dosage for all populations, personalize drug therapy based on genetic makeup, reduce the number of available medications, or understand the genetic origins of a disease. So, okay, you all answered. So you see the results at the end. According to the ASHP statement, which roles can the pharmacist play in the world of pharmacogenomics? I won't read the answers because they will be confusing. Just read them. Okay, so we have the right answer is C, and we have like quite. So now Sliman is at the top of the scoreboard. The 4th question is, which year did direct-to-consumer genetic tests first emerge in the market? Which year do you think it first emerged? Do you think it's 2001, 2007, 1996, or 2013? So the right answer is, okay, the right answer is number 3, which is 1996. And not all of you did get it wrong, right, actually. Okay, so the final question is, which of the following is the most probable barrier for pharmacogenomic testing for financially limited patients? Access to good physicians who can interpret results, access to wide variety of medication options, social educational barriers, or test cost and coverage by insurance. So the answer is, unfortunately, the cost and coverage by insurance. So thank you all who participated with us. And here are the results. Thank you all. Okay. don't know how to stop this.
It stopped.
Okay, okay, it stopped already. Okay, then thank you for your patience, for staying for us until this moment, and for your active participation and insightful contribution. Thank you for all the speakers for their great talks, and we hope that this webinar has enhanced your understanding and about pharmacogenomics and sparked further interest in this field. And we are all wishing you that continued success and inspiration in your pursuits. And we look forward to seeing you in our next webinars and future events. Thank you all. Have a great evening. Goodbye.
Bye.
Thank you very much. Bye-bye.
Bye-bye.
Bye. Assalamu alaikum.
Wa alaikum assalam wa rahmatullah.